This discussion is on the pathophysiology of the liver. The liver is a complex organ. It has many contributions to homeostasis that often are not appreciated until the liver functioning declines. The most common causes of chronic liver disease are alcohol-induced liver disease, non-alcoholic fatty liver disease, and hepatitis C. The death rate from chronic liver disease and cirrhosis has been rising in the United States. 1.9% of the adults reported receiving a diagnosis of liver disease in 2016. There are increases that are attributed to the obesity epidemic and the associated rise in non-alcoholic fatty liver disease and alcoholic steatohepatitis, or NASH as it's called. Primary caregivers are ideally in a place to counsel patients about the management of lifestyle, like alcohol intake and obesity, to help reduce liver disease prevalence, and about screening for the silent hepatitis C. Management of liver disease is often supportive because it has a chronic progressive liver disorder that can only be cured by a liver transplant. The liver is the largest solid internal organ located in the right upper quadrant. The primary cell types of the liver are hepatocytes, sinusoidal endothelial cells, Kupffer cells, stellate cells, and cholangiocytes. The liver does receive dual blood flow. 25% of the blood is fully oxygenated and provided by the hepatic artery. 75% comes from the portal vein. This combines deoxygenated venous drainage of the intestines, pancreas, and spleen, making the liver the portal or the gate between the intestines and the systemic circulation. The liver is positioned to absorb the primary products of carbohydrate and protein digestion, use abundant amino acid supply to synthesize a large number of proteins, regulate glucose homeostasis. It's the first in line of the immune defense against bacteria that enter the blood across the intestinal wall. It detoxifies or metabolizes drugs and toxins that are ingested orally. It synthesizes and secretes bile acids that is needed for fat digestion and absorption. And it secretes detoxified endogenous and exogenous compounds into the bile so it can become fecal excretion. The liver has 4 lobes: the right, the left, the caudate, and the quadrate, and it receives 25% of the cardiac output. The abundant blood supply is integral to the liver's metabolic functions. The biliary tree is also crucial to liver function. The cystic duct connects the hepatic duct to the gallbladder. Here, bile is stored between meals. Bile will then flow into the bile duct. This joins the pancreatic duct and goes through the sphincter of Oddi into the duodenum. The hepatocytes are the functional cells of the liver and are the most abundant cell type. These hepatocytes perform metabolic, storage, and synthetic processes. This image is the sinusoid structure. The sinusoid walls are made up of specialized liver sinusoid epithelial cells. The sinusoid is separated from the surrounding plate of hepatocytes by a space of Dease, which is directly connected to lymph drainage. This space of Dease between the sinusoids and the hepatocytes contains hepatic stellate cells. These cells store vitamin A and are normally inactive. However, they do become active if the liver becomes inflamed. When these stellate cells are activated, they cause fibrosis and cirrhosis that is associated with chronic liver disease. The immune and reticuloendothelial function of the liver is conducted by the Kupffer cells. These are resident macrophages that reside in the sinusoids, and it also is conducted by lymphocytes called pit cells and dendritic cells. The cells provide constant immune surveillance for molecules and pathogens that enter the body through the gut wall. The stellate cells in the space of these are normally quiescent or quiet, but can become activated in response to any liver damage, and the stellate cells are what contribute to liver cirrhosis. There are two vascular streams that supply the liver with blood. The hepatic artery branches from the abdominal aorta, providing fully oxygenated arterial blood to the liver. The portal vein combines the venous drainage of many of the abdominal organs, and it makes up to roughly 75 to 80% of the liver's blood flow, with blood that is rich in nutrients after meals, but this blood is oxygen poor. Hepatic blood and bile flow through a liver lobule. The blood flows from the periphery of the lobule toward the central vein, while bile flows in the opposite direction to the periphery of the lobule. Hepatocytes have abundant smooth endoplasmic reticulum and rough endoplasmic reticulum. The smooth endoplasmic reticulum contains many enzymes for drug detoxification and cellular metabolism, where the rough endoplasmic reticulum is the site of synthesis of proteins that are going to be secreted. The hepatocyte structure gives clues to the varied processes that's carried out by these cells. There are abundant rough endoplasmic reticulum and Golgi apparatus for protein synthesis and secretion, shown in number 1. The protein transfer is assisted by large gaps or fenestrations between the liver sinusoidal endothelial cells. The apical membranes of adjacent hepatocytes are sealed with tight junctions around the site of bile secretion to prevent toxic bile components from damaging the hepatocytes or leaking into the blood. This is number 2. The smooth endoplasmic reticulum contains enzymes of the drug metabolism and metabolic processes. Fuels are stored in the form of glycogen deposits and lipid droplets. The cells are polarized with basolateral surfaces enriched by folds where they contact the space of these for interchange of proteins between the blood and the hepatocytes, which is shown down in the bottom of the image at number 3. The biliary tree is formed by a small bile caniculi draining plates of hepatocytes that coalesce to progressively larger channels. Ultimately, the vessels form the bile duct that drains bile from the liver and the gallbladder into the duodenum. After meals, the portal vein blood is rich in the absorbed nutrients from the GI tract and pancreatic hormones. This allows the liver to conduct the reactions necessary for energy storage during times of fasting. Carbohydrate metabolism is aimed at maintaining a stable blood glucose, and this is a key responsibility of the liver, as the liver regulates the blood glucose by controlling the uptake, production, and release of glucose. When there are periods of excess glucose, the liver sequesters glucose as glycogen during glycogenesis. During fasting, glycogen is broken down in glycogenolysis and releases the glucose for use by the body. The liver also has the ability to synthesize glucose from amino acids during periods of low blood sugar glucose through the process termed glyconeogenesis. The liver is the dominant organ of lipid. The liver is the dominant organ of lipid metabolism. The liver can also use glucose to synthesize cholesterol, which is essential for the production of plasma membrane components, bile, hormones, and certain vitamins. The liver can also synthesize high-density lipoproteins that are necessary for cholesterol distribution and uptake throughout the body and return to the liver. The liver synthesizes and breaks down amino acids in support of protein synthesis and in the process of glyconeogenesis. Hepatocyte processes of metabolic homeostasis, drug metabolism, and bile salt production require an extraordinary number of intracellular membrane and secreted proteins. Dietary fat absorption will depend on the fat solubilizing properties of bile, which is synthesized in the liver, secreted into the biliary tree, and stored in the gallbladder. Bile is composed of water, bile salts, phospholipids, conjugated bilirubin, and additional compounds that are detoxified by the liver and destined for excretion by fecal matter. Bile does serve two functions: fat digestion and toxin excretion. Bile salts are required for digestion of fats through emulsification and for absorption of fat digestion products and fat-soluble vitamins from the intestines. Bile is also a route of excretion for bilirubin, xenobiotics, and endogenous compounds that have been detoxified by liver enzymes. Bile is the major route of excretion for potentially detrimental lipophilic substances and the major elimination route for cholesterol. The liver is responsible for detoxifying ammonia through the synthesis of urea, producing a compound that is readily cleared by the kidneys. Ammonia produced by gut bacteria reaches the liver through the portal vein. The liver also forms ammonia through amino acid metabolism. Ammonia is toxic to the brain, and it can impair brain function, thus leading to a change in mental status that can eventually result in seizures and a coma. The liver is the main organ of energy metabolism of carbohydrates, lipids, and amino acids. The liver is responsible for the conjugation of bilirubin and the excretion of bilirubin by the bile ducts. Bilirubin is constantly generated from heme released with the breakdown of aging red blood cells by the reticuloendothelial system. Unconjugated indirect bilirubin is initially hydrophobic and nonpolar, and it'll travel in the circulation system bound to albumin. Hepatocytes will take up bilirubin and conjugate it to glucuronic acid. Conjugated or direct bilirubin, glucuronide, is hydrophilic and is secreted into bile. In the gut, bacteria further metabolizes bilirubin to urobilinogen, a fraction of which is reabsorbed and ultimately then excreted by the kidneys. Much of the remaining urobilinogen is converted to stercobilin and is excreted in the feces, adding the characteristic brown color. Hyperbilirubinemia produces the characteristic yellowing of the skin that is known as jaundice. Elevations can be caused by excess production of bilirubin, a decreased uptake by the liver cells, decreased conjugation, decreased secretion, and bile duct obstruction. Hemolytic anemia is a common cause of excess production of bilirubin. Lab measurements of conjugated and unconjugated bilirubin are used to determine the cause of jaundice and the site of liver impairment. Endogenous hormones and xenobiotics, which are endogenous compounds that are foreign to our body, both of these are detoxified and then excreted by the liver. The outcome of hepatic metabolism is to make a substance easier to excrete. This occurs by making a product or a compound more water soluble. Metabolism of an exogenous drug. Most of the substances are metabolized in two processes known as phase 1 or phase 2 reactions. Depending on the phase, the reactions add a hydroxyl or another chemical reactive oxygen-containing group to the drug. The other phase, phase 2, will conjugate the drug or the phase 1 metabolite with a larger hydrophilic group. This will help to increase the water solubility and renal elimination. Any compound that has nonpolar metabolites are routinely eliminated by the biliary fecal route. Liver metabolism can diminish the blood levels of drugs administered orally through the first pass effect. The liver can metabolize some of the drugs before it exits through the hepatic vein to systemic circulation. Oral medications absorbed in the GI tract circulate via the portal vein to the liver prior to entering the systemic circulation. Liver metabolism can either activate a prodrug or inactivate a portion of the administered drug, thereby reducing the amount of active drug that reaches the circulation. Ultimately, the first pass effect can reduce the amount of active drug available to the body for pharmacologic action and delay the onset of the drug effect. Drugs administered through the IV route do not undergo absorption through the GI tract and will not undergo the first pass effect, thus leading to higher levels of the active drug and higher bioavailability. The liver contains the largest number of fixed tissue macrophages, which are also known as comfort cells. This makes it an important component of the immune system. The comfort cells are responsible for the clearance of gut bacteria and foreign proteins. The liver can store iron in the form of ferritin and can store several vitamins, including A, E, and B12. The liver is responsible for maintaining systemic iron homeostasis, and it also synthesizes hepcidin, a plasma protein that blocks cellular transport of stored iron back to circulation, thereby decreasing circulating iron levels. The liver has the ability to regenerate after an acute injury. However, once a patient has severe liver disease or cirrhosis, the liver loses this regeneration ability, and after removal of a portion of the liver, the donor liver will then regrow in another region and restore normal levels of liver tissue and function. As hepatocytes are damaged, enzymes of liver function are released into systemic circulation, allowing for quantification in the serum or the increased amounts in the serum. The elevation of these enzymes is a marker for hepatocyte damage or death. ALT is the most specific marker for liver damage because it is found mainly in hepatocytes. GGT is sensitive to hepatocellular damage caused by alcohol ingestion. ALP is a marker for cholestasis and bone turnover. As hepatocytes are damaged, the liver's protein synthesizing capacity is now reduced, lowering blood levels of albumin and clotting factors. As the damage worsens, prothrombin time and international normalized ratio, or the INR, increase. Differential diagnosis is aided by patterns of bilirubin elevation. Increase in direct bilirubin are usually related to hemolytic anemia. Increases in direct bilirubin are a result of the inability of hepatocytes to eliminate bilirubin or of blockage to the bile ducts. The gold standard diagnostic tool to evaluate tissue injury and fibrosis is the liver biopsy. Symptoms of acute liver disease are routinely nonspecific, however, may include fatigue, malaise, nausea, and a loss of appetite. Some individuals may experience right upper quadrant pain and weight loss. Acute liver failure has severe symptoms and can be defined as the abrupt start of symptoms such as jaundice, coagulopathy, encephalopathy in a patient that was previously healthy. Drug-induced liver injury is the most common cause of acute liver failure. Excessive ingestion of acetaminophen can cause acute self-limiting hepatitis or fulminant liver failure that needs transplant. Acetaminophen can cause damage by a single toxic ingestion, as in an overdose, or by chronic ingestion over periods of time, a few days. Acetaminophen toxicity has 4 stages, so identification of an acetaminophen overdose is crucial to an individual being saved. as well as is the antidote, which is N-acetylcysteine. This can be administered to save someone's life. Cholestasis is a state of interruption of bile secretion caused by intrinsic liver dysfunction or processes outside of the liver. The bile duct can be blocked by gallstones, neoplasms, or pancreatic inflammation. This causes a cessation or a stoppage of bile flow. Some medications disrupt bile secretion at the hepatocyte canicular interface, stopping bile flow. Also, spontaneous cholestasis is an occasional complication of pregnancy. Excessive bilirubin leads to a hallmark sign of jaundice, dark urine, and light-colored stools. Pruritus or itching is also a common manifestation of cholestasis. Hepatitis is a general term for liver inflammation. It can be acute or chronic. Acute hepatitis is inflammation that lasts less than 6 months, and chronic is inflammation that lasts longer than 6 months. Chronic hepatitis can come from a variety of sources. It can be a viral infection related to alcohol liver disease, non-alcoholic liver disease. And chronic hepatitis increases the risk of hepatocellular carcinoma. Viral hepatitis is differentiated into 5 different forms. They are lettered A through E. Hepatitis A does not cause chronic infection or long-term hepatic damage. The virus is spread through the fecal-oral route, and the infection actually, to gain an infection, requires direct contact with an HAV, as it is known, or hepatitis A virus infected person, or the consumption of contaminated food or water. Exposure to HAV is likely in regions that have poor sanitation where the water can be contaminated. Hepatitis B is an acute liver disease or chronic disease, depending on the response of the immune system and the age of the infected patient. Hepatitis C is the most likely to become a chronic disease, leading to cirrhosis and carcinoma. Hepatitis D requires concomitant infection with hepatitis B. Hepatitis E is transmitted via fecal-oral and is mainly seen outside of the United States. The largest numbers of infected individuals for hepatitis B are in Africa and Asia, where the infection is actually acquired at a young age. Chronic HBV infection can cause fibrosis, cirrhosis, and hepatocellular carcinoma. This virus for hepatitis B is the only DNA-containing hepatitis virus. HBsAg is the first hepatitis B protein marker detected after hepatitis B infection and is detectable at the start of the clinical symptoms. The development of the antibody indicates immunity to HBV and clearance of the virus. HBV, or hepatitis B virus, can be prevented through vaccination. Once a patient develops chronic infection, it is likely that treatment will be lifelong. The image depicts a comparison of tissue structure within the top is the normal liver cells, and the bottom is the liver that has advanced fibrosis. Ongoing inflammation promoted by activated Kupffer cells and lymphocytes stimulates the stellate cells. And if you recall, the stellate cells only happen when there is injury to the liver. The stellate cells increase the production of an extracellular matrix, particularly collagen. Thickening and hardening around the sinusoids restrict their diameter, increasing vascular resistance and contributing to portal hypertension. Sinusoidal endothelial cells lose their large fenestrations, and this decreases the capillary permeability. Cirrhosis is often described as scarring of the liver, and it is characterized by a dysfunction or degeneration of hepatic cells, inflammation, and fibrous thickening of tissue in the liver. Once it develops, cirrhosis is progressive and it is irreversible. Complications of cirrhosis can affect many organs and include hepatic encephalopathy, hepatorenal syndrome, portal hypertension, jaundice, hyperammonemia, coagulopathy, splenomegaly, hypoglycemia, and various infections in ascites fluid. The most common cause of cirrhosis are chronic viral hepatitis, alcoholic liver disease, and non-alcoholic fatty liver disease. Portal hypertension results from the increased hepatic resistance to portal blood flow that commonly accompanies cirrhosis. So this image is of portal hypertension and the complications that result from it. The blue boxes show the sequential changes occurring because of increased hepatic sinusoid resistance. The pink boxes are the final consequences of the changes. Multiple factors and pathways lead to a pathophysiological consequences of increased hepatic sinusoid resistance that cause fibrosis and cirrhosis. Remember, activated hepatic stellate cells promote the fibrosis around the sinusoids and increase the resistance in that region of tissue. For alcoholic liver disease, risk factors for progressive liver damage are a result of excessive alcohol ingestion, and these can include the being of male sex, genetic factors, nutritional status, hepatitis B virus, and hepatitis C infections. Various complications can result from excessive alcohol consumption. Steatosis, which is an infiltration of fat into the liver. Also, alcoholic liver disease progresses in stages from fatty liver through hepatitis and progressive fibrosis to cirrhosis. The other disease process is non-alcoholic fatty liver disease, which combines non-alcoholic fatty liver and non-alcoholic steatohepatitis. This is defined as fat deposits into the liver. Poor diet, uncontrolled diabetes, metabolic syndrome, and an inactive lifestyle have been found to be significant contributors to the development of non-alcoholic fatty liver disease. Chronic hepatitis B infection can cause fibrosis, cirrhosis, and hepatocellular carcinoma. Hepatitis C infection is the primary cause of liver transplant in the United States. Most patients with acute hepatitis C are asymptomatic and underdiagnosed. If symptoms occur, they usually are self-limiting and nonspecific. Chronic infection of hepatitis C can lead to cirrhosis and as well carcinoma. Cirrhosis and carcinoma. Hereditary hemochromatosis is one of the most common inherited diseases in the United States. It is an autosomal recessive disorder with incomplete penetrance. It is the most common genetic liver disorder in patients of Northern European ancestry, but it is rare in other lineages. This is associated with chronic elevation of circulating and tissue iron levels that can actually result in hepatotoxicity, heart disease, diabetes, and other end organ manifestations. Infants and children younger than 2 years of age have decreased drug clearance and longer drug half-lives, making them extremely susceptible to drug toxicity. A neutral gastric pH, delayed gastric emptying, immature bile production and transport, as well as reduced renal clearance, all result in decreased drug metabolism for children and infants younger than 2. Beginning at ages 2 to 4, children can begin to metabolize drugs similarly to the same rate as an adult. Age-related changes in the liver affects the size, perfusion, metabolism of medications, and composition. The primary diseases of the liver in the geriatric population are viral hepatitis, non-fatty liver disease, alcoholic liver disease, autoimmune hepatitis, primary biliary cholangitis, and hepatocellular carcinoma.